and pass on the baton to Rosemary. Thank you.
Thanks very much, Sharon. Welcome, everyone. And today we have a special guest. Alexa Heekes is a health data scientist and a bioinformatics doctoral candidate with experience working with high throughput genomic data, as well as architecting and developing solutions to integrate, analyze, and visualize public health data at scale. So quite a mouthful. Alexa is driven by the potential that the ethical use of data has to empower and strengthen healthcare systems, particularly in resource-limited environments. Alexa's, just for interest, her doctoral thesis topic is the investigation of HIV-TB co-infection through analysis of the potential impact of host genetic variation on host pathogen protein interactions. So we can quiz her on that afterwards if there's time. But Alexa, thanks very much for agreeing to share this with us. And we're all looking forward to it.
Great.
Thanks.
Thanks, Rosemary, for the introduction. Hi, everyone. I hope you're all doing well and keeping safe. Today, I will be talking to you about our experience in the Western Cape province of South Africa, specifically the rapid enhancements that we've made to our existing data systems to help with tackling and tracking the COVID-19 curve. So just a brief outline before we start. I'll start by briefly describing the health system and health information systems in our province and what requirements our health system specifically had for the response to the pandemic. I'll then talk about an existing health information exchange in the province that predated the pandemic and how we have rapidly evolved the existing tools and systems to support the operational, management, and research needs that have been spurred by COVID-19. And I'll round off with some of the lessons that we've learned. So the health system in South Africa consists of both a public and a private sector. In the Western Cape province, around 75% of the population rely almost solely on the public sector, while only 25% use the private sector, but patients can utilize services in both sectors. The public sector, what makes it quite unique is that it functions as a single service provider. So this means that patients are free to move between facilities and healthcare workers, and also the healthcare workers can work across facilities, and patients are unlikely to always see the same healthcare provider at every visit. The public sector in the Western Cape services over 5 million active patients at any given time across various levels of service, including community-based services, primary care, and hospitals. The feature that makes the province unique, and this is something we owe to Rosemary and her colleagues, is that we have a single patient registry. And this has a unique health identifier that gets assigned to every patient, distinct from our national identifier. And the unique identifier and its use has been gradually rolled out over the past almost 30 years to all hospitals and primary care facilities in the province. There's also only one patient management system, which is used by the 53 public hospitals that we have. And there are 2 primary care patient management systems, all of which have an online connection to the patient registry, which ensures that all data is captured against the same unique identifier, regardless of what facility the patient is at. There are also multiple other routine information systems for other clinical services, such as laboratory results, drug dispensing, HIV and TB management, and community-based screening and referral programs, which all capture data with a shared unique patient identifier. All the systems are generally securely accessible over the provincial intranet, and usually access is restricted to devices that are managed by the IT department in the province. But unlike systems in other countries, we don't have an EMR or electronic medical record. Instead, healthcare workers still largely use paper folders, as shown in those pictures on the right. And we have armies of invaluable clerks that capture key information after the health visits. We have a few nascent EMRs that are slowly gaining traction. However, the administrative burden of data collection has still led to the favoring of clerk capturing. And in contrast to the public sector, in the private sector, each practitioner and each practice functions as a single service provider, and information systems vary between the facilities and the services that are offered. They also don't routinely use EMRs. So now I'm going to move on to the thing that's changed all of our lives, and that's COVID-19. And here I have a very brief timeline of events, starting from the first reported case in South Africa on the 5th of March. A week later, the first case was reported in the Western Cape, which coincided with almost with the day that the WHO declared COVID-19 a pandemic. Just over 2 weeks after the first case in the country, our president declared a nationwide lockdown that was one of the strictest in the world, which has slowly been eased over the months. Within a month after the lockdown began, the Western Cape was declared as the South African epicenter, with just shy of 1,300 known cases and 28 deaths. And by the 10th of May, we had 100 deaths reported among the known COVID-19 cases, and by 13 June, this had increased to over 1,000 deaths. With all these changes, the health system inevitably had a lot of requirements for the information systems. And in early February, discussions had already started about what the health system would need to fight the pandemic. But discussions about what the information would look like that we would need and what our systems would need to be able to do only really started in March and started very quickly. And many of these requirements that I've listed were actually there from the beginning, but others have evolved as case numbers have increased and the manual detailed case annotation that we started with at the beginning became impractical. So we needed a data capturing interface firstly to annotate all the case notes as well as to capture details about close contacts. Initially, the contact tracing teams were using Excel spreadsheets, but this very quickly got out of hand. We also needed access to secure access to tools and reports via the user's personal devices and over the public internet connections, as we were getting many university students and support staff, NGO staff, and staff in facilities that weren't managed on the provincial network that were going to be supporting contact tracing, and they would also need access to reports and tools, and they would largely be working remotely. We need to make sure that our health workers would have visibility of medical history and health service encounters remotely, because many of them would not be able to necessarily access the folders or the information stored in paper folders across the facilities. And with a new pandemic, new systems have started rapidly being designed. New data was captured into existing systems, and we've got data from the public and private sector that needed to be merged in order to have appropriate and thorough case management. We've had to know which cases were healthcare workers, as well as being able to geolocate patients to enable hotspot mapping. And finally, we needed tools for case management and case prioritization, as well as reports that would support our managers and epidemiological analysis. So this brings me to the system that already existed in the province. I'll put the spotlight on the Provincial Health Data Centre, or the PHDC for short. The PHDC is a South African health information exchange that we like to emphasize always is powered by people and supported by technology. At the PHDC, we've been integrating patient-level data from all the routine health information systems in the public sector for over 5 years. This has largely been possible due to the widespread use of the unique health identifier that is shared across the health information systems, making data harmonization that much more easy. Our data center contains data from over 30 sources for over 14 million patient identifiers, and in some cases, the data sources go back over 20 years. Even my now long since deceased great-grandmother has an entry on our patient registry. We incorporate most of our data sources daily. which means that our reports and applications give visibility to data that was captured the previous day. And this has really allowed the data to be actionable, and it's already been used in an actionable way for TB case management and HIV case management. So some of the key features of the PHDC that I'd like to highlight is that once our data are imported, we have automated and manual curation processes that enable the data to be cleaned and mapped to common concept dictionaries that can be shared across the sources. We then try to get the maximum benefits out of all the data by inferring things like health service encounters. For example, if a patient was dispensed a drug, we can infer that they visited a facility on a given day. And just knowing a patient's movements across facilities can provide a lot of information about their health. However, we also infer health conditions from the data. Unlike many other systems in the private sector and internationally, which largely rely on the use of clinical coding, such as ICD-10 and SNOMED codes, we use all the routine data, such as the lab results and the drugs dispensed and the ward information, to infer the conditions a patient may have. And all this information is exposed to our users via actionable tools. These include things like patient-level list reports that can be used to filter patients that are in need of follow-up. We also send out patient-level alerts every morning to requesting health providers to notify them of patients in specific need of follow-up. And we've developed an application called the Single Patient Viewer, which exposes the electronic medical history of a patient, combining all the key information that would usually have been stored in paper folders across various facilities. To support the COVID-19 response, we were lucky to have many of the key features in place in our Single Patient Viewer application, even though many had not been widely used. So patient viewing was the most widely used feature of the application and was well established, but we had also activated recently data capturing forms, which are built in a highly configurable manner, such that very minimal web development or coding had to be done to get the form elements and rules working to the requirements of the case and contact follow-up teams. The highly configurable nature of the forms also meant that they could change rapidly as the pandemic requirements changed, and they've gone through several iterations already, maybe even 50 or so iterations of different kinds of field combinations and rules that the users have requested. We also have reports accessible via Single Patient Viewer in also a configurable manner where we can easily customize icons and report filters. And just for COVID, over the past, 3 months, we've developed over 20 different reports for 5 different categories, especially for COVID. Single Patient Viewer has also got follow-up functionality where you can phone or SMS patients, and this enables the user to contact the patient free of charge. We had to build in some tools for case prioritization, especially as the case numbers started rising and follow-up capacity became limited. We also needed to enable a feature to register patients, since for the first time the application was also being used to monitor COVID information for private sector patients, and users would need to capture their information using a similar unique identifier to other patients. Finally, we needed to build in some tools for capturing of close contacts that met the needs of the contact tracing teams. From a data perspective, we've also had to rapidly integrate additional data sources, primarily the private sector laboratory results for COVID-19, but also from national lists of cases, new contact tracing applications that have been developed and rolled out by the mobile networks. We've had to update our imports, especially of the lab data sources, to occur more frequently throughout the day rather than just once in the morning. And data that gets captured into our application gets updated in our reports almost real time, so that the reports are updated automatically. Finally, we've had to ensure that users could access the application securely off of our provincial intranet, which was made possible using something that the province had just rolled out before the pandemic hit, which was third-party authentication through Microsoft Azure. And this has allowed a user to securely sign into their Microsoft account for their institution and authenticate before being able to access the application. And this has also enabled the rapid onboarding of new users, with over 700 new users just added in a few short weeks. So I'm just going to show a few pictures of different things that we've used to support the operational needs. And this is just a screenshot of the the login page with the sign in with Microsoft button at the bottom. Here I have an obfuscated screenshot of the dashboard view for a single patient. And in this view, you can just about see all the information that was ever captured electronically about a patient in the health services. You can see their inferred health conditions, including COVID-19, which is the first one under that inferred episodes there. You can see all their lab results, their hospital and primary care encounters, all of their appointments and drugs. If you keep scrolling further down the page, you would be able to see their drugs. You can also click on the capture button and annotate their COVID episode or any of their other episodes. Here I have some screenshots of the capture forms, including the case form in the middle, which has all the different fields that the follow-up teams wanted to capture about the patient, such as were they an essential worker, how many contacts did they have, do they have any comorbidities, etc. Then we've got the contact form, which allows you to capture contacts and then indicate which case they are linked to, and also just capture some information about those contacts. Are they asymptomatic? Do they need an isolation or quarantine facility? And then on the far left, I've just got the form that we use to add new patients to the registry. So you're able to search the existing registry. If you can't find the patient, you can add them. Finally, for the operational requirements, we have a variety of reports for different purposes. And these include things like lists of healthcare workers, lists of essential workers, lists of admissions for COVID cases, as well as lists of the cases and their contacts. Here I have some screenshots of a few of these reports. My apologies, the headings and pictures seem to have all gotten a bit muddled up. But the first one on the left is the downloadable case list. And this list essentially is a list of all the known COVID cases. It contains all the information that has been captured against that case or has been integrated from the various sources. The downloadable case list tends to get downloaded into Excel, which is often the most familiar tool for our users. But interactively, you can click through it into that patient's dashboard, or you can click on the View Contacts button and see a list of any contacts that have been captured for that patient. Then just below that, I've got the case assignment and address curation report. This allows users to interactively edit the case assignment details for multiple cases at a time, rather than going into each individual case. This was requested by our users because it became quite time-consuming to go from the case list above it, click on each patient, go into their dashboard, click on the capture button and edit their details. But this just allows them to very quickly allocate cases to various service areas from one view. And it's been particularly important for patients where the addresses have been difficult to geocode automatically. Then finally on the right, I have screenshots of the interactive case prioritization tool. And this allows users to filter out high priority cases for follow-up in a simple 3-step process. So first they apply their filters using dates or service areas or comorbidities and age, and then they can select patients from the list with higher priority cases already being highlighted just to draw attention to them. And then they can click on the individual patients to view their details, click through to the single patient viewer to edit their case record, or even click through to the National Health Laboratory Services to view the original lab results for the case. In addition to the patient level more operational reports, we've developed a series of management reports and tools. This one is the public facing dashboard. It is updated once a day and is accessible to everyone in, I think, the world actually. The data from this dashboard are sent to the provincial leadership and they get summarized every day into a table that looks like this. And those get sent out by the provincial premier with other updates to anybody who's interested in finding out about what's going on with COVID-19 in the province. Then in addition to the public-facing management reports, we also have internal management reports, which provide live views of various data, such as the number of tests we've done, the community screening that's been completed, and how many patients have been referred for testing, the number of admissions by hospital to general and ICU wards, and various other things. We've got tools for hotspot mapping, etc., which aren't yet public-facing, but provide a lot of guidance to managers. Finally, because of the work we've been doing over the past 5 years and more to consolidate information and identify comorbidities such as HIV, TB, diabetes, hypertension, chronic kidney disease, and chronic pulmonary disease, we've been able to already support analyses of risk factors for death in COVID-19 patients. Within a few hours, we were able to pull together this data set of around 3 million patients who had been active in primary care, along with their ages, sex, comorbidities, and details of death. And in other settings, it was already known that risk factors for COVID-19 death included older age, male sex, diabetes, cardiac disease, kidney disease, as well as being overweight. But little was known about HIV and TB. And given the high burden of HIV and TB in our setting, we were able to start analyzing these data. So after preparing the data set, my colleagues found that similarly to other settings, diabetes, hypertension, and old age are all risk factors contributing to COVID-19 deaths. They also found that HIV and TB were significant risk factors, but their risk was not as pronounced as it was for diabetes. For every 100 people in the public sector who have died from COVID-19, they could attribute 12 to HIV, 2 to current TB, 4 to previous TB, while 52 to diabetes. Most notably, there seemed to be very little difference in the risk factor for HIV in virally suppressed patients versus patients who were not virally suppressed. So further analysis is underway to try and see why this may be, and if perhaps it is just a data glitch, or if there is some scientific basis for this. As we are only just nearing our peak of infections, we know that we still have a lot of work ahead of us, but so far we've learned a lot of things that are definitely worth sharing. It was truly invaluable to have systems in place before the crisis hit, and we would encourage any settings where systems are currently being built to support the pandemic to continue to improve and develop those once things start to quieten down. People always rush to bring out the flashiest technology to solve a new problem, but at the end of the day, we've realized that while good technology is of course extremely important, the people behind it are far more important. Dedicated data engineers, data scientists, and data capturers are what makes these systems successful. That said, it's also very important that your users understand the limitations of the data available. We can only make so many inferences and patch up so many gaps with data triangulation, and it's very important that good data are captured into our systems. The biggest example of that for us was the address and contact information. These data are notoriously outdated in our systems, as they are not routinely updated at patient visits. Patients also sometimes use a different address than what their true address is when they go and visit a facility. And so this has made contact tracing efforts a little bit harder than they needed to be, and I hope that the pandemic builds enthusiasm to routinely keep patient contact details up to date, something that we've actually been raising for a long time, specifically for follow-up of TB patients. So getting those contact details and addresses up to date will benefit all conditions. Then no matter how great we and others thought that our tools were, there are still some users and groups who prefer what they are used to, Excel being the favorite, and it has been a battle to get consistency across different user groups. However, the incentive of the automated reports has definitely promoted the use of our tools, and we continue to update and adapt them to support user requirements. User support has also been a full-time job, and it's been very difficult on about a team of about 7 people who are actively integrating the data sources and building the reports. But we've been lucky to have additional support from new staff members, as well as some support from other departments to help with onboarding of users and creating user guides and that kind of thing. finally, the biggest lesson has been there is no time for downtime. We have been online around the clock, but it has been great to watch people come together and work as a single team. This is just a very small piece of the pie of all the different things that are happening in the Western Cape, and it's been a privilege to be a part of that team. So thank you so much for your time. I hope you enjoyed hearing about our work. I'll leave it up to you guys to ask any questions. And just so you know, I've included a few links to resources if you'd like to learn more about the data center or follow up on what's happening with coronavirus in the Western Cape. Thank you.
Thanks very much, Alexa. So there's a question from Linda.
Yes, I'm reading it. I have
Are you reading? Okay.
I have always been impressed with service delivery in Cape and Gauteng province. I'm aware that Discovery and Vodacom have partnered to deliver an online healthcare platform for free consultations on COVID-19. Are you working alongside health sharers and mobile networks, especially in contact tracing? Yes, so I haven't actually heard about anything specifically with Discovery and Vodacom. I will bring that up at our next meeting on Wednesday, but the past week we've been working with the system created by Telkom called Telkom Track and Trace, and they've partnered with the NICD to SMS, or actually WhatsApp, results to users. So what they do is they send you an SMS, and from the SMS, if you would like to opt in, you can jump onto WhatsApp, and in WhatsApp you basically communicate with the bot and they tell you your results, and it's been really great. And they've started sharing that data with us, so we have now got updated contact details and addresses actually for a lot of patients. And with those information, we can also get a sense of whether they've engaged with the service. They can indicate if they need isolation and quarantine and that kind of thing. So it's going to be really useful. And we're looking forward to integrating those data. But I'll definitely follow up with whether or not that integrates with what's happening between Discovery and Vodacom. Then in terms of the health insurers, they have been working alongside us. There's been a lot less patient follow-up in the private sector than in the public sector. Most patients tend to go for their test in the private sector, but then they still get followed up by health workers and contact tracing teams in the public sector. And then if the services are available to Zimbabweans and Malawians, etc., the public sector is available to everyone. I think maybe when national health insurance is implemented, it'll come with a little bit more red tape. But yeah, that's the reason our unique health identifier isn't the South African identifier, so anyone can access the services. Thanks. Okay, we've got another question from Anna. What is the medico-legal perspective with inferred medical conditions rather than validated ones, and the decisions based on such conditions? Was there resistance from primary care with sharing their data? Okay, so in terms of the medico-legal perspective, we've been very clear with all of our users that the conditions are inferred, and they're just basically as flags, more like at risk, or just highlight the fact that a patient might have a specific condition. And we have several alerts throughout our tools, as well as quite detailed terms and conditions that explain that anything that they see, even the lab results and the drugs, do need to be clinically validated, because there's still a chance that people have used each other's folder numbers, or we've done an incorrect patient linkage or something like that. So it is still on the clinician to check and validate the data before making any decisions. But it is something that we're acutely aware of and constantly thinking about how we can make sure that data are validated. And then in terms of primary care data being shared, because the province is a single service provider, we haven't had to worry as much, because I think what I've heard in the UK at least, each facility or service is separate, and they would have to share their data and opt in to share their data. Whereas because the province is a single provider, Every time you go to the facility, you may not see the same person. You're not expected to go to the same facility every time. Facilities get closed down all the time, vandalism or fires and that kind of thing. It's not, it hasn't been an issue. Rosemary can maybe talk about the history of that.
I know I'm typing, but just say thanks for the answer. That's really interesting to hear.
Sorry, what was that? I went offline there.
Just the kind of sharing of data across the province, because the public sector is a single service provider, and how that differs to other settings.
Yeah, basically the private sector owns their own data, so you'd have to enter into data sharing agreements with each entity. The same as we've had to enter into data sharing agreements with the City of Cape Town, for instance, if that explains it.
It does, thank you. Can I also just say it's really, really impressive about actually the automatic data cleansing in a previous role. I was the e-health lead in an NHS organisation here, and I was involved with the design of a clinical data accumulator called Sky Store, which brought together numerous sources similar in a much smaller scale than the one you're doing here, and actually cleansing and validating data from each different source was perhaps the biggest headache we had.
It's definitely the biggest headache for us as well, but we're determined to make it work. I think that's all you need, is a whole bunch of people who are determined, and yeah, and the time to do it, I suppose.
I really enjoyed the session as well, and I think you're doing a fantastic job. Could you just reiterate your relationship with Microsoft there? I didn't get that completely.
So the province uses Microsoft tools. We have all of our tools are Microsoft based, really. So our databases are on Microsoft SQL Server. We recently moved to their Azure space now that they're hosting in South Africa. And we use Outlook and all of those kinds of things. So we have Microsoft enterprise tools accessible to us in the province. It's often been a criticism by other people who would promote the use of open source tools, but the difference was that we wanted to make sure that anything we've built can continue to be sustained in the province using the systems that are approved by our managers and that kind of thing. So that's why it's all been built with Microsoft. And one of the features that was accessible with Microsoft was this third-party authentication, which has really been great. It's allowed us to be able to share our access to our tools with other institutions like the universities and the City of Cape Town, which is our local municipality, which also use Microsoft, and they can then securely authenticate without having to log on to our provincial network.
That's fab. In terms of cost, is that the cost efficiency working with Microsoft from an African perspective, and do they get access to the data, and is the data source left within South Africa, or is it in the cloud?
The data is all within South Africa. It was only a few months ago that we moved to the cloud-based hosting, but it's still within the South African data center, in fact, in Cape Town, and then we have got a data center in Johannesburg as well. Microsoft doesn't have access to the data. It's all managed by our security teams, and we've got a very strict security network that manages traffic. For instance, we can't even connect to different kinds of FTP sites and VPN and that kind of thing, it's very strictly controlled, so the data is very secure within the provincial network. In terms of cost, it's like I said, it's been Microsoft has been used for years within the province, and they have got an agreement. We do get things that are much. I don't know what the pricing is really. I don't really. I'm not involved in that, but I know that it's at a reduced cost in line with their pricing frameworks.
Thank you.
Can I just ask, since if you don't mind me asking another question, I don't want to monopolise. Have you been able to find any examples or whereby the system, while providing information of interest, has actually made a material difference to the way that you've managed the COVID outbreak?
Not specifically for COVID yet, and that is something I was thinking of as I was making these slides, is now we need to think about how we can measure the impact of the systems. But I think the biggest one has been allowing us to have real-time data accessible, especially even just for the management reports. We're the only province where we can every day tell the public how many people in their area are COVID positive cases. So that's been a big help. And then I think being able to see patients' medical history has also been a big feature, and it's been brought to life by this very terrible pandemic, where people have now had to use the tools and have been able to see the value. But we're definitely going to have to do an evaluation of the impact that it's had.
Yeah, we're doing something very similar in NHS24 at the moment, in terms of trying to see whether our data doesn't just look backwards, but whether it can look forwards as well.
I've got a question about your PhD. No, not really. I didn't understand any of it. So, is there any other questions? No, in that case, I'm going to end the recording.